Hello everyone, this is Dr. Divyam Goswami and we have a special guest with us, that is Dr. Husayn Aly, a consultant psychiatrist, a fellow of Royal Australian and New Zealand College of Psychiatrists, practicing at Hirondelle Private Hospital in New South Wales, Australia, with a special interest in adult ADHD, treatment-resistant depression and neurostimulation. Welcome, Dr. Husayn.
Thanks, Divyam. Thanks for inviting me to be a part of this.
Yeah, and today we'll be talking about treatment-resistant depression and the role of TMS in the treatment. So let's start, Dr. Husayn, straight away.
Certainly, Dr. Divyam. Let's do that.
Yeah. So first of all, I'd like to know that from what I gather from my reading is that we have a pretty much simple definition of treatment-resistant depression, that if a person is not responding to two separate classes of antidepressant, that is termed as treatment-resistant depression. Am I right?
So I guess, Divyam, it depends on where you look, but generally that's a generally very well accepted definition of treatment resistance. So a failure to respond to two or more antidepressants on an adequate dose for an adequate time period is sort of conventionally what we all accept. But I think, look, clinically, there's a whole lot more to that sort of definition, and we don't apply definitions to patients, we actually treat patients. So I think things like readdressing the formulation, if someone hasn't responded to two or more antidepressants, we try and we dig deeper, see if there's any other factors that may be influencing the formulation. For example, any organic causes like thyroid problems, iron deficiency, vitamin D, but other psychiatric comorbidities, for example, ADHD, things like bipolar spectrum, trauma, insomnia, or sleep architecture in general, substance use and psychosocial factors. I mean, often the label itself of treatment resistant should prompt reassessment. And I think it's important to remember that many patients labeled as treatment resistant are diagnostically incomplete, and treatment resistance should trigger reassessment, not just resignation.
Yeah, so you have partly answered my next question, that why don't many people respond to antidepressant? And partly you've answered that because they may have the medical conditions or they may not be compliant on their medication, that is so-called pseudo-resistance. But if everything is fine, I mean, the person is medically fine, if the person is taking his or her medications regularly, then what could be the reason why someone doesn't respond to two or more classes of antidepressant?
Look, this is a very good question, Divyam, and I think this has prompted a lot of debate, specifically recently. I think when we look at depression as such, it's heterogeneous. Two people can have the same diagnosis, but the illness course and the illness progression is very different. I think clinically, what is obvious is we need to move beyond just protocols that we see. There's different biological and psychological drivers. As I mentioned, things like trauma, ADHD, sleep architecture or disruption in sleep architecture, personality disorders, substance use, and sometimes genuine refractory illness comes into play. I guess, when we see non-response, obviously, a very detailed history is required, but also thinking beyond just the medications and the illness and thinking into the different networks that are involved, and remembering that depression is not a syndrome. Depression is a syndrome. It's not a single disease entity. And two people can meet the criteria for depression while having completely separate underlying drivers for their illness. Does that resonate with you?
Yeah, it does. And Dr. Bhavya Bhansali has joined us. So Dr. Husayn, he is my colleague and a very dear friend who is co-organizing these DiGo Talks webinar with me.
Pleased to meet you.
Hi, Dr. Husayn. How are you?
Good, thanks. Good. Pleased to meet you.
It's a pleasure hosting you.
Thank you.
And
it's a pleasure to be here.
Yeah, we are hoping for a wonderful session, as always.
Excellent.
Yeah. So moving on with the treatment-resistant depression, I think you talked about the psychology and talked about, so I have this complaint with most of the psychiatric bodies and most of the bodies that set up the guidelines for treatment-resistant depression, that you define treatment-resistant depression by response to antidepressant and not to psychotherapy. So why is it so? And do you think that psychotherapy has a role? And if it has a role, then why do we only rely on antidepressant response to define and to set the guidelines for treatment-resistant depression?
I think this is a very good question. And I think your complaint is very valid and one that I had very early on in my career. I think what I have noticed, working in psychiatry for, 10 plus years is that formulation matters more than diagnostic labels. And when we actually look at different neural circuits, that should dictate how we take a history. So I actually am in agreement that this definition is there to come to a diagnosis. But as I said before, a diagnosis can be present in two different patients, but they can respond to treatment completely differently. So I very much, yes, do believe in psychotherapy, particularly when there's, underlying trauma, personality disorders, substance misuse. I think there is definitely a role of psychotherapy in these particular patients. And different types of psychotherapy are useful for different types of psychiatric comorbidities when they exist alongside depression.
Yeah. So you definitely do agree that psychotherapy has a role in depression and also in treatment-resistant depression as well, isn't it?
Definitely does. Yes, it definitely does. And I think the degree of psychotherapy or the type of psychotherapy should be driven by one's own formulation with the patient. So, conventionally, we look at different types. So if it's someone with sleep disturbance, we can look at CBTI. If it's depression, anxiety, we look at more cognitive behavioral therapy. If it's trauma, there's multiple different types of therapy available, whether that be EMDR or psychodynamic psychotherapy. I definitely think that psychotherapy definitely has a role in treatment-resistant depression, and that should really be guided by our formulation for the patient.
Yeah. As far as treatment-resistant depression is concerned, what percentage of patients do you see in your practice? I'm not talking about the literature or what the book says, but I will be asking about your experience, that if you are seeing 100 patients of depression, how many of them would turn out to be treatment resistant, meaning they don't respond to 2 or more classes of antidepressant?
Look, I would say quite a high portion, Divyam, because number one, and I would probably say I would say it would be 60+%. And I think the reason for this is that in Australia, the referrals to me come either by the patient's primary care physician who has tried one or sometimes two antidepressants. So they may have tried, something like an SSRI or an SNRI. They may or may not be at a high dose or an appropriate dose. They may have tried another one, and the patient still hasn't, responded. I also get sort of referrals from other psychiatrists who refer with the view of getting TMS or esketamine therapy. So my referral base actually consists of quite a high portion of patients with treatment-resistant depression, but it doesn't stop me from going down the pathway of still formulating them in a way in which I can understand exactly what's going on and which neural circuits have been affected.
Yeah. We hear it a lot of time from our colleagues and from the general population as well, regarding the chemical imbalance. So how much a role chemical imbalance has to play in treatment-resistant depression, apart from other factors?
I think as I've sort of, from the beginning of my career in psychiatry till now, I have seen the field evolve considerably. And I think this terminology of chemical imbalance has been historically useful, but scientifically oversimplified.
Yeah.
I think modern networks are, like modern models are, highly multidimensional, and the literature talks a lot about network dysfunction, neuroplasticity, like stress systems, inflammation, cognition, sleep architecture, trauma, psychosocial stresses. And I think the serotonin narrative was probably more helpful initially, and it's obviously a bit easier for a patient to understand that. But now our understandings are far broader, and I think the modern understanding of depression is far more network-based than neurotransmitter-based. And look, depression is not simply a serotonin deficiency, and I think that's proven over and over again.
Yeah, so this is a very important point that you highlighted, and that I think needs to go in the general public as well, and to our colleagues in other specialties of medicine as well, that it's not just the chemical imbalance. I mean, chemical imbalance can be a part of it, but we have other factors, as we say, biopsychosocial. So we have the psychological factors, we have the social factors, and even in the biology, we have so many other factors like neuroinflammation and as you rightly said, the neural circuit dysfunction and neuroplasticity and so on and so forth.
Definitely. And I think when it comes time to doing an initial assessment on the patient, like really asking targeted questions to focus on the formulation of the patient, to address the psychosocial, factors, but also, when I was doing my exams, we also started to introduce, not in addition to biopsychosocial, cultural and lifestyle factors as well, because I typically find in private practice those things are critical to developing a comprehensive formulation in a patient.
Yeah. Since you are referring to formulation and you have used this word quite a few times, so I would rather ask you to clarify and to explain to our viewers, what do you mean by formulation?
Well, at the most basic level, Divyam, I'd probably say to you is what is happening, or why is this patient presenting to me at this particular point in time in their life? Okay. So that basically examines from the day they were born, or actually preconception, to right now. Okay. Has there been any birth injuries? Has there been any childhood abuse? Has the patient's parents got divorced and resulted in childhood trauma? Has the patient has there been sort of maternal mental illness that has affected, bonding and attachment? Has the patient been bullied at school? Has the patient had a series of failed relationships? Has the patient had substance use at an early age? Has the patient experienced, multiple career failures or not been able to progress, with their secondary or tertiary studies? There's all of those things, but in addition to that, obviously, is there physical illness? Or is there a thyroid dysfunction? Is there iron deficiency? Is there disruption to sleep architecture? So all of these, as you say, biopsychosocial, and then I've added cultural and lifestyle factors going in to determine why this patient is presenting today with some mental health complaint that we have to get to the bottom of. And that, I totally agree, may not be able to be determined by just looking at guidelines or saying, okay, this patient hasn't responded to 2 antidepressants from 2 different classes for an adequate dose for an adequate time. And I totally agree that, we need to dig beyond that definition to determine exactly why this patient hasn't responded.
Yeah. So I think Dr. Bhavya had a couple of questions. So if you want to ask those questions at this point in time.
Yes. So, Dr. Hussain, I had a question for you that what are the neuromodulation techniques which are, in regular practice in Australia for treatment-resistant depression?
So in terms of, neurostimulation, I think, look, the 2 main ones which are available for us generally in private practice are transcranial magnetic stimulation and ECT. So TMS, as it's known, is available as outpatient therapy. The patient comes in. We do what we call as a mapping session where we identify the dorsolateral prefrontal cortex, and then they come in and they basically have, generally speaking, 35 sessions of TMS. There's some difference in protocols. Sometimes some protocols deliver 2 sessions in a day. And then gradually, as the treatment progresses, we taper down towards the end to minimize the chance of a relapse. So look, TMS is something that, I'm involved a lot in, which I've seen, significant improvement on patients with treatment-resistant depression. ECT is another one which is available to us. It's generally more so done in the public sector rather than the private sector, although there are some private facilities that do offer ECT. In the public sector, there's 2 types. There's voluntary and involuntary ECT. If it's involuntary, the psychiatrist needs to go to a tribunal to get permission to do ECT, and for that, a second opinion by another psychiatrist is required. If it's voluntary, the patient can sign a consent form and undergo the procedure. They get reviewed by an anaesthetist, and the procedure is carried out. In the private sector, I think best practice is that even though the patient is voluntary, they usually do get a second opinion to ensure that the indications for ECT have been met, and the patient undergoes ECT in the private sector under the care of a private psychiatrist.
Yeah. I would like to follow up with a question that how does the TMS actually work in the brain in simple terms, and which patient is an ideal candidate for TMS?
So, I mean, not much is known, I guess. Okay, let's talk about the ideal candidate for TMS. I think it's basically a patient who has typically the patients we think about are patients with treatment-resistant depression, haven't responded to 2 or more antidepressants for an adequate dose or an adequate time, generally in 2 separate classes of drugs. Patients who've had intolerance to medication. And like if after reviewing their formulation that they're appropriate for TMS, we sort of take them up for TMS. So I think patient selection is very important to the outcome of TMS. And I think TMS works best when it's integrated into a broader treatment framework. So I guess TMS is not a universal solution, but in the right patient, it can be transformative. And I think patient selection, matters enormously. In terms of how it works in the brain, look, not much is actually known about this. Like similar to ECT, we don't know much about why neurostimulation works. The psychiatrist who discovered ECT did so by chance, and basically from that time onwards, it's been sort of modified until we've developed different protocols. Like generally in Australia, we use the right unilateral electrode placement to minimize cognitive impairment, and I think this is sort of reasonably well accepted throughout the world. Fortunately, TMS doesn't have these cognitive side effects that I'm aware about, and essentially it is usually helpful to use TMS before going to ECT, again in the right candidate.
Right. So, if we compare the efficacy of TMS with the antidepressants, how is it faring up? And overall, how is it faring up in Australia as a neuromodulation technique?
So I think it's difficult for me to comment on like Australia in general. I think I could comment generally on my patients. So as I said, look, I think 60+% of my patients have some form of treatment resistance. So I guess I know I keep going back to the formulation, but look, essentially when I go back to the formulation and find that there's something obvious missing, for example, like if for example, a patient has a thyroid dysfunction and hasn't been corrected and they're being treated for depression, I mean, I usually try and, treat that or organize treatment for that to happen, before even considering TMS or any other sort of change to their pharmacotherapy. In terms of like medication as such, if someone comes to me for TMS, it doesn't mean necessarily that I won't try them on another antidepressant if I think it's going to work. But usually, look, with respect to like the published guidelines on TMS, I think approximately 60% of patients improve to some degree with TMS. Some of them above 50%, some of them less than 50. And that number is generally measured on their rating scales. So if they sort of do a pre-TMS rating scale, a mid-TMS rating scale, and an end TMS rating scale. So that's, I guess, how we measure like improvement. And there's several domains which are measured. But look, within my own patient cohort, and I've just done recently an audit on this, 80+% of my patients are experiencing substantial improvement, like with TMS. And I think the reason for that quite high number is patient selection.
Right. And in your experience, have you had any side effects with TMS that you would like to highlight?
So there is some side effects, like the most common ones that I experience is tiredness, usually on the day of the procedure, and headache. They're the common ones. I'd probably say 30 to 50% of patients suffer from those things. Um, there is sort of a chance of seizures. Now, the literature says between 1 in 10,000 and to 1 in 30,000, depending on what literature source you look at. Touch wood, I've never seen a seizure in my career secondary to TMS, but we have the necessary protocols in place to terminate a seizure if one does exist. The other thing which I have seen in TMS is if someone has pre-existing tinnitus, sometimes TMS can make that worse. So if someone does have pre-existing tinnitus, I usually get an opinion from an ENT surgeon, before continuing. And likewise, if someone has, epilepsy or sort of a history of seizures as well, I'd usually get an opinion from a neurologist before, carrying out TMS. But generally speaking, I think the adverse, and this is why I like personally TMS so much. In my experience, I've noticed adverse effects from TMS are actually generally less than medication. So you don't get, like the GI symptoms of an SSRI or any sexual dysfunction like an SSRI causes. You don't get, the weight gain that something like mirtazapine causes, or you don't have to worry about, dietary interventions like you do in some MAO inhibitors. Look, overall, I really like TMS for its side effect profile, and generally it's very, very well tolerated. Um, and, coupled with, you know, gradual clinical improvement, and, the other advantages that TMS offers, such as, it's an outpatient therapy. Like patients can come in, they can drive into TMS, they can drive home, they can go to work. Like after the procedure, it's fairly non-invasive. They're awake throughout. There's no anesthetic, which they need to sort of worry about. Um, as far as I'm concerned, TMS is practical, non-invasive, and integrated into someone's daily life. And the fact that patients are aware, functioning, and often return to work immediately afterwards means it's less disruptive than many people may expect.
Yeah. So, whenever we are giving ECTs, we have something called the maintenance ECTs in order to
Yes.
prevent the relapse or recurrence. So, is there
Hmm.
something called maintenance TMS as well?
So, yeah, I guess there could be, depending on the presentation, depending on the formulation. So, like in Australia, so the government funds 35 sessions of TMS for the patient um, as a one-off, and then if there is a relapse, the government will fund an extra 15 sessions. So in total, the government funds 50 sessions, which are broken up into 35 and 15. Look, there are some patients whose illness is highly treatment resistant, and they do need maintenance TMS, just like they otherwise would have required maintenance ECT. And they're happy to pay out of their pocket, when that does arise. But look, I would say the proportion of people that I've seen require maintenance TMS is significantly less than those that require maintenance ECT. I don't have a reason why that's the case. I don't do maintenance TMS that frequently. I'd probably say less than 2.2 or 3% of my patients require maintenance TMS.
Well, doctor, thanks a lot. And now we'll move forward with Dr. Divyam for further questions.
Sure.
Yeah, so Dr. Hussain has been very good with answering the questions to the point and in very brief. So actually, we are well within the time and we have covered a lot of ground. So thank you, Dr. Hussain, for that. I think we have lost Dr. Hussain, and it seems there is some problem with the connection on his side.
My apologies.
Yeah, was there any problem?
There was a problem. This person keeps ringing me on WhatsApp, and I've disabled the WhatsApp on my phone, but it's still coming up on my computer. So I'm not entirely sure. I've closed the app down, but yeah, it's still coming up.
Okay, no worries. I think we can edit this part later on when we put up the recording. So no worries at all.
Let me just message them and just say so they.
Sure.
Okay. Hopefully they won't ring back now.
Yeah, so I was just saying that, you have been very specific and to the point regarding answering the questions and being very brief. So that's a very good thing for us that we are well within the time and we have covered a lot of ground.
Excellent.
Yeah. So moving forward, I just wanted to ask that you talked about TMS as a modality for the treatment of treatment-resistant depression. But I've heard, and I think you would be the right person to answer this question, that in the Western world in general, that I think we would consider Western Europe, United States, Canada, and Australia, and New Zealand, I've heard that in the Western world, we, you guys are using much less ECT than what should be used. Do you agree with that?
It's a difficult question to answer because I'm not sure how much ECT you guys are using. But look, I've worked across multiple health systems, like specifically in psychiatry in the UK and Australia, and I think given the sort of autonomy that the patient has is probably respected slightly more in the West. So, for example, in Australia, like for someone to have involuntary ECT, look, obviously they need to there needs to be a demonstrated course of action by the psychiatrist taken to treat their illness. So, for example, depression or psychotic depression, there needs to have been, pharmacological treatment. They may or may not have required admission into one of the psychiatric intensive care units. They needed to have tried, antidepressants frequently, with antipsychotic augmentation, so that when you're presenting the case to a tribunal, they can actually see that there is a genuine need for ECT. And look, when there is, I think that like our guidelines are fairly clear about when someone needs ECT. The tribunal will give permission, but there is probably and I think that was the case in the UK as well when I saw ECT being carried out in the UK, and the degree to which patient autonomy was taking place. But I think overall, I mean, when ECT is required, I think the tribunal usually, I haven't seen a case where a patient has, there's a genuine risk to life. For example, psychotic depression where someone's not eating or drinking, or there's significant self-harm, where there's suicidal ideation with plans, that a tribunal hasn't given permission to go ahead with ECT. Sometimes, I mean, at these particular junctures, I guess, in treatment, and I'm sure you would notice this as well, that insight is compromised and patients don't always have the necessary insight. And I think that's a large part of what you and I, Divyam, deal with as psychiatrists. Like, insight is compromised. And sometimes convincing a patient or even convincing a patient's family to undergo ECT is quite a difficult task.
Yeah, so that was exactly what I was asking, that not using a lot of ECT in the Western world, is it just because of the science behind it, or is it more to do with the administrative reasons, the regulatory reasons, and the logistic reasons?
So, I mean, I would say that in the units that I have worked with, like the acute units, I think ECT is used appropriately. So I guess I don't have a benchmark in terms of absolute figures of how ECT is used in India, but or non or developing countries. But I would say that ECT is used appropriately, and I would say there is a high respect for a patient's autonomy. With respect to, would I personally like to, use ECT more often in some of my patients? Probably yes, because I think I would see that, they would be put out of their misery sooner, and they would be able to, get better, gains in terms of their illness. But the system exists to promote patient autonomy, and there are sort of rights that the patient has to be able to exercise their discretion.
Yeah, I think that sums it up very well, that there's a lot of respect for the patient autonomy uh, in the Western world as compared to the developing countries. And that may be one of the reasons why the rates of ECT are much lower in the Western world as compared to the developing countries. Uh, as far as the treatment resistant depression is concerned, we had one webinar with an Australian doctor who is specialized in psychedelic assisted psychotherapy, and we had more than an hour of discussion on psychedelic assisted psychotherapy with Dr. Anthony Block from Australia. He is the founding chairman of the Australian Medical Association for Psychedelic Practitioners. And
Mm-hmm.
so I would like to ask, that what is the role of psychedelic assisted psychotherapy in treatment resistant depression? Especially, you are the right person to answer this question, because Australia was one of the first, I don't think one of the first, but it was the first country to legalize psychedelic assisted psychotherapy.
So I think there is a role. I have, referred one of my patients for psychedelic assisted psychotherapy. I think, you know, the way I like to work, Dr. Divam, is I like to, start trial, medication, um, go from, a treatment with less side effects to a treatment with, that may be more effective, but, have more side effects, and, gradually progress along that pathway. So, look, after medication, TMS, S-ketamine, ECT, I think psychedelic assisted psychotherapy is probably the last form of treatment or the modality of treatment that I use for a number of different reasons. Number one, it's extremely expensive, and like there's a minority of the population that can afford this. Number two, access is quite restricted. There's not a lot of practitioners doing this
Even in Australia.
overall. Even in Australia, like not everyone, like you have to be specifically trained in psychedelic assisted psychotherapy. And I think, thirdly, I think there is also an X factor, like a black box, with regards to, stigma in the public. It's just sort of largely unknown given it is new. There's a lot of psychiatrists that are sort of ambivalent about referring for psychedelic assisted psychotherapy. I certainly think it has a role in treatment resistant depression, but it is not a go to form of treatment that is generally used by most psychiatrists just because of the cost factor.
Yeah. So, according to you, the use even in Australia still remains limited because of the cost factor. Is it covered under insurance?
I think it's not covered under health insurance, but my understanding is, and don't quote me on this, I think if someone has a workplace injury, it may be covered, but it's not covered generally under standard health insurance, although there is, I think, one insurer that partially covers it.
Yeah. So, while answering this question on psychedelic assisted psychotherapy, you also touched upon the algorithm or the approach that you follow in your patients with treatment resistant depression. So, following up on that, I would like to ask that do you choose the treatment modality for treatment resistant depression based on the target symptom or based on the residual symptoms of depression? Like, I would do it many times in my practice, that if the person has severe anhedonia or if the residual symptom is anhedonia, then I would choose bupropion or low dose aripiprazole or maybe even a pramipexole. So, how correct is that? And what do you do in your personal experience?
So I do agree with the way that you practice, and I think in our guidelines, our mood disorders guidelines from the Royal College of Psychiatrists, they do promote different antidepressants targeting different residual symptoms, which I certainly use those guidelines when I'm targeting depression. But look, I guess before I do that, again, I look at the formulation and see if there's something else that I can do, which doesn't necessarily always involve medication. Um, I know we've spoken a lot about this, but treating organic causes or looking into any personality dysfunction which may exist, any substance use issues, or any problems with ADHD, trauma, sleep architecture. Like, I think, generally speaking, in the earlier days of working as a psychiatrist, I didn't realize the impact that these comorbidities had on depression or mood disorders in general. But as I've worked in psychiatry longer, I've realized that treating these things can sometimes mitigate the need for escalating treatments.
While answering these questions, you are repeatedly talking about the comorbidities, and one of the comorbidity that you have been talking about since the beginning of the webinar is the ADHD. Now, this is again in contrast to what we see and we practice here in India. Like, we do treat a lot of pediatric ADHD, but we don't diagnose much adult ADHD. So, and you have a special interest in treating adult ADHD as well. So, my question is that if a person has adult ADHD as a comorbidity to treatment-resistant depression, how would you approach such patients?
So I would take a history, like initially, take a history, focus a lot on their developmental history, and focus a lot on some of the cognitive symptoms, the arousal symptoms, the attentive and, I guess, focus symptoms of a patient. Determine, like, the degree of trauma that the patient has undergone. And I think not only will you start ticking off some of the DSM criteria for like ADHD, but some of the fundamental things with ADHD, for example, people not realizing their true potential, executive dysfunction, problems of the frontal lobe, like sequencing, planning, routine problems with routine, problems with sleep, and failure to follow. You can usually identify some repeatable issues. So, for example, people have problems with relationships, like repeated failed relationships or repeated failure in studies. If I get this history, it enables me to go into looking further at ADHD and whether this is a possible confounder or comorbidity in a patient presenting with treatment-resistant depression. And sometimes treating ADHD itself, you sometimes get a high yield in terms of being able to treat depression and ADHD at the same time. And frequently you don't need to escalate treatment for depression if ADHD treatment is adequately treated.
So I think that is an important take-home message for the viewers, especially from developing countries like India, where you don't diagnose a lot of adult ADHD. And following up on this question, Dr. Ali, I think there is one criteria in DSM-5-TR where you need to have at least some of the symptoms of ADHD before the age of 12, also to diagnose a patient as adult ADHD. So how many of your patients do actually fulfill that criteria? Because what I think would happen is that a lot of people would not recall any symptoms before the age of 12. And does that hinder the diagnosis of adult ADHD according to DSM-5-TR?
Very good question. And one question which is not asked enough. So ADHD assessments, like as you would probably know from treating children with ADHD, they're multimodal assessments. So essentially, we have to get history from the parents, the school, and anything else. Obviously, the psychiatrist will take a history. So in adult ADHD, we actually we look for these symptoms before this cutoff age of 12, which is still quite arbitrary. But essentially, I still check for collateral history in every adult that comes to me. So, a parent, grandparent, like guardian of a patient that was knew the patient before 12 years old. The other things that we can, like, the other main thing that I do check for in when I'm diagnosing someone with adult ADHD is I ask them to bring in their school reports. And believe it or not, quite a high portion of patients have school reports available. And usually the symptoms of ADHD have presented in the form of comments from their teachers prior to the age of this arbitrary figure of 12. But, I guess to sum up, collateral history and school reports usually give some clue of symptoms before this age of 12.
Yeah, and Dr. Hussain, I just wanted to tell you from my personal experience that I've been treating patients of pediatric ADHD, and it has been one of the most rewarding disorders to treat because, it responds to medications like magic. And especially, we have other disorders like intellectual disability, autism spectrum disorder in pediatric population where you don't get the results, and that's sometimes very frustrating for the caregivers and for the physicians as well. But ADHD remains one of the most rewarding disorders. So is it so even in the adults?
Yes, definitely. It definitely is. I mean, like the feedback that I frequently get is that, this changed my life. I've seen basically people not being able to do who have had repeated failures at university or tertiary level, who are able to go back and finish their studies. I've seen people who have been like high performing people with ADHD who have had, very rigid routines that have sort of helped them succeed. But after treatment, they've been able to go on and they don't suffer from that sort of cognitive fatigue or executive dysfunction as much, and they're able to go ahead with their life, increase improve their career, increase their income, have better relationships with those around them, have better routines, have more structured lives. And look, the level of organization, focus, concentration, planning, all, the symptoms of the frontal lobe are significantly improved. So it definitely is as rewarding treating adults as it is treating children. It's just different kinds of uh, things that improve depending on the various life stages.
Yeah, I think we have 10 to 15 more minutes because we are already about 1 hour into the webinar. And can we do 10 to 15 minutes more?
Sure.
Yeah. And following up on your answer about adult ADHD being rewarding, I would like to share a personal experience of treating a patient of ADHD. I think that patient was 10 or 11 years old, and he was doing quite badly in his school. The grades were dropping. And after I started treating him with just one molecule, that was atomoxetine, he improved 100%. And then we got his story into the media as well, that the child is actually doing very well in the school, and he has got some appreciation from the school as well, that he is getting very good grades in the school.
Yeah, and look, these kinds of stories, are amazing for the patient, but it also reassures us that, there's been a lot of negative press, certainly in Australia about, overdiagnosis and over treatment of, adult ADHD. But treating ADHD, as you alluded to before, is extremely rewarding, and for a psychiatrist, and being able to treat patients and see their functional gains improve in their life is something that uh, which you really feel happy about for the patient, that they're able to achieve this. And look, I'm not really surprised that it made the media, because these kinds of stories are, really resonate with the public.
Yeah. Uh, the next question that I had was, as you alluded to, a lot of comorbidities that may be contributing to the treatment resistance in depression. So I would like to ask that, does the presence of a comorbidity always mean that a comorbidity is contributing to the treatment resistance? Because sometimes I think that we get to see a lot of people with subclinical hypothyroidism even in the general population. Like, I mean, it could be as high as 10 to 15%, and the rates of subclinical hypothyroidism have skyrocketed in past few years. So sometimes I literally think that we do get a diagnosis of hypothyroidism or subclinical hypothyroidism, but it may not be actually contributing to the treatment resistance in depression.
Very good question. I would, my response to that is basically, I think it depends at what stage the patient presents to you. Okay, so if they present to you in their first episode of depression, and basically they get a quick response to treatment despite subclinical hypothyroidism, it may not be contributing. But if a patient has tried, for example, 3 or 4 antidepressants, and you're not able to determine any other factor in their formulation that may be contributing, this is something that I would get taken seriously, to determine, if this in fact is having an impact on their mood. So I would have a discussion with, like, usually the patient's primary care physician, unless they're being looked after by an endocrinologist, and get their opinion and say, look, essentially, this is my situation. I'm not able to find any other sort of comorbidity. It could be sort of a genuine treatment resistance, but I've got a doubt that this might be contributing. What are your thoughts? And what are your thoughts about, treating this subclinical hypothyroidism? And we can have we can monitor the patient after that. So look, I generally, in that case, wouldn't take a decision on my own. I would try and collaborate with the patient's other team members, and see if, what their thoughts were, and come to a sort of a mutually agreeable solution. But I guess, have I done this before? Have I got a subclinical hypothyroidism treated and the patient improves? I guess the answer is yes. But I wouldn't necessarily have done that in their first presentation. It would probably have come to me after the patient's tried multiple antidepressants and we're looking to escalate treatment. So would I try fixing that before taking the patient to TMS, ECT, or esketamine? Yes, I would, because um, I think the returns may be worth it.
Yes. So, as you referred, when I said biopsychosocial, you added to it lifestyle and cultural factors also. So,
Yes.
what do you think? How much of a role has lifestyle factors to play in treatment resistant depression, especially when you have famous studies which say that exercise is as good as antidepressant, or the effect size is almost as equal as the antidepressant? So, do you really prescribe lifestyle changes or lifestyle modifications to your patients of treatment resistant depression?
Absolutely. It's probably one of the mainstays of it's certainly one thing that I encourage in most patients. So like in terms of, and I generally try and cover off on those five domains, biopsychosocial, cultural, lifestyle, in every patient that I sort of see with treatment resistant depression. So it's the unfortunate thing with treatment resistant depression is that depression erodes the very systems people rely on to try harder. So the motivation circuitry is impaired. So there may be some functional masking, but many patients are already functioning at an enormous psychological cost. So if I tell someone to go out and do a 30-minute run, that I know is going to be highly unlikely that that happens, right? But we start small. Okay, can you walk for 1 minute in the house every single day? Yes, no one's ever refused to do that. And that's where I start. Okay, then the next time, okay, can you walk for 5 minutes in the fresh air once a day? Again, no one responds to that. And gradually, we get up to situations where they are able to undergo sort of aerobic fitness, and it does have significant gains on their mood. Combining medication with exercise is definitely something that I promote very heavily, as well as diet as well.
Yeah,
But essentially, that is something that I spend a lot of time talking about.
yeah. And I also wanted to tell you that, the community that we started, the DiGo Talks community that I started about 3 or 4 years back, it actually started with, the focus on longevity, because at that time I was not into psychiatry. And it's only since last 2.5 years that I am into psychiatry residency. So before that, I was heavily advocating on lifestyle changes and prevention, not for treatment-resistant depression, but for longevity, but it forms a part of the treatment-resistant depression treatment as well.
Definitely. Like I'm a big advocate of lifestyle changes, generally in the form of diet, exercise, but also psychotherapy, and essentially, dealing with people's trauma, dealing with people's personality vulnerabilities, dealing with substance misuse issues, basically has a tangible impact on the circuits of the brain which are responsible for low mood.
Yeah, so as we wind up our webinar, this would be, I think, the last question. And, my last question would be on the role of ketamine or S-ketamine for treatment-resistant depression. What I gather from what I've read in various books and literature is that we use ketamine especially for suicidal patients. But I think in the 14th edition of Maudsley guidelines, they have mentioned ketamine for treatment-resistant depression as well. And what we use here in India, or not speaking for India, but speaking for myself, what I've used is, IV ketamine. We don't get the intranasal S-ketamine here in India. So we often do use IV ketamine, uh, zero point 0.5 milligram per kg of the body weight or 45 minutes infusion. And the problem that I really see with ketamine is that there are good effects, but the effects tend to wane off. So, how is your experience, and what is the role of ketamine or S-ketamine in your practice?
So the role of esketamine in my practice is for treatment-resistant depression. It is what we classify as one of the novel treatments for depression. There is I don't use IV ketamine in my practice because of the ability to monitor the patient, but we use intranasal ketamine. So essentially, the guidelines are largely the same. Like, a patient hasn't responded to 2 or more antidepressants in different classes for an adequate dose for an adequate time, and basically it can be helpful in treatment-resistant depression. Look, overall, there's been mixed results in my patient cohort. So some patients have got a really good outcome with esketamine, and have not required, maintenance therapy, beyond the 8 weeks. There are some patients who have got a good response, but after the sort of the initial 8 weeks have required ongoing treatment with esketamine to maintain their mood. I haven't yet got any data on this in my patient cohort. I am working on that sort of at the moment. But look, I think, the follow-up time, for these patients is, significant. But look, I do share some of the same sentiments as you have, that patients do require like ongoing, or a portion of patients treated with esketamine require ongoing treatment to keep a sustained response.
Yeah, so we do have pretty much the same experience with ketamine, although we don't have esketamine here in India. But let me tell you, Dr. Hussain, this was an amazing webinar. And if I had to describe this webinar in one word, I would say insightful.
I'm glad to hear that it was insightful for you. I hope I was able to add some value to both of your learnings and also your audience as well.
Yeah, and it's not just for us or for our community, because this recording goes on the YouTube and it will stay there forever, maybe helping a lot of psychiatrists, psychologists, early career psychiatrists, and also health enthusiasts and general public.
Definitely.
Yeah. Bhavya, want to say something?
Yeah. So it's been an amazing webinar. It was so insightful. Got to know a lot of things from your perspective, from your experience. So it was truly invaluable.
I'm glad you enjoyed it.
Yeah. Yes.
Yeah. Uh, Thank you, Dr. Hussain. I'll just forward you the link once we upload it on YouTube. And
Excellent.
thank you again.
It's
Yeah.
a pleasure.
Thanks a lot.
Thanks a lot.
Thank you.
Bye.
Bye.
Bye, guys. Take care.